Good morning, everybody, and thank you for this opportunity to talk to you. There couldn't be a better place, really, to launch the strategy. The timing was perfect. We have an audience here of 1,000 people interested in patient safety, but it's quite a difficult task. And I recently saw this tweet. I've disguised him, so you don't know who it is. I hope he's not in the audience. And here's the challenge. So he says, I know he hasn't spelt out dated right, you know, sometimes these conferences can be a little bit stale and sometimes the questions are a bit stale. This one I know isn't like that, but my challenge is to try and inspire you because what we're talking about is really important. I've got to get that message across. And I was thinking through this thinking, okay, so this is our problem. We're all about to go out for bad coffee. What do I do to inspire you? And I thought I would turn to somebody who was a great thought leader, one of the world's leading philosophers, not Donald Trump. So I went for the Dalai Lama to see what he had to say on the subject. How could I think of something inspiring to get this message across? And if you read through this, you'll see, well, this doesn't really leave us in a good place, does it? So the Dalai Lama wasn't the answer. So we had to switch to Dr. Seuss. So my aim for this morning is to get you to the point where you all believe that the future can be better than the present and that you have the power to make it so. So that's our aim, with the benefit of Dr. Seuss. We know it's a big problem. You'll see in the papers today a lot of talk about this figure. We know it's an extrapolated figure. It's the best we've got, and I make no apology for trying to measure what's going on in patient safety. There's a huge cost burden. There's a huge cost burden in litigation. So about a year ago when we were at this conference, and I was just moving jobs, so I was a week before I started the job and keeping a low profile, and I was sitting next to Sean Linton at the dinner when the previous Secretary of State announced that he wasn't going to arrive the following morning. And Sean said, oh my goodness, how do I fill that half an hour? And on the other side of Sean was Sir Bruce Keogh, who, before I could stop him, said, don't worry, Aidan and I will do that. And I found myself up here on stage, and one of the questions was, what's the first thing you're going to do in your new role? And I said, I'm going to go out and listen to people. And those who were paying attention will have noticed that the first thing we did was produce a document. And you probably thought, so much for listening. And the more cynical will have said, here we go, another top-down document telling us what to do. But there was a reason for this. In fact, two reasons. One, the long-term plan was coming out, and we needed to emphasize the continuing importance of patient safety to go alongside that. But we knew we didn't have the answers. The second reason was that we felt it was better to have a document for discussion, some provocations, some ideas for you to discuss around. But we genuinely wanted to go out and consult, and so that's what we've done. And here was the timeline. We were asked to write a new strategy. We produced a consultation document that was genuinely that. We went out and consulted and had 527 feedbacks. Now, I know there's over 1 million people in the health service and countless patients and carers, but a lot of these were institutional. So the number of people represented in these figures and all the other things we did of going out and having focus groups, and there was even a, what is it called, Twitter-thon or something like that. I don't tweet anymore because every time I do it seems to cause a storm, so I've stopped doing that. But today what we're seeing is the culmination of all that produced in this document. There are printed copies, but I would encourage most of you to read it online. There are not enough for everybody. We're trying to save trees. And this was who responded. So you can potentially see, possibly not from the back, this broken down by numbers. And there were a lot of institutional responses, NMC, GMC, CQC, as you might imagine. And we have read and taken on board all those comments, and there were comments from patients and carers as well. And generally, you agreed with the aims and the principles of the strategy as laid out, which was a good thing. If you're the one who didn't agree, welcome to democracy. Most of you did, which was encouraging. And here's the highlights of what you told us you supported. So firstly, you supported having a patient safety strategy. I'm not sure what we were going to do if you'd said you don't want one. Secondly, the principles, and of course the focus on just culture. And we had broken it down into 3 strategic aims, initially called Insight, actually Infrastructure and Initiatives. We changed the wording of that based on feedback and using those as the organizing principles. You supported the development of PSIMS, we'll talk more about that, and more on safety too as an area for development. You supported the idea of having patient safety specialists and the curriculum around patient safety, as well, of course, as patient involvement, as you would expect. You challenged us around some of the other ideas. So we had a strategic approach which was to be the best in the world, and you will hear people talking about that probably shortly. But here's the thing. It's the language of competition. And actually, we want the whole world to be better. And all of you in this room will care about the fact that in low and middle income countries, the burden of patient safety harm is much greater, and we have the potential to help with that. So actually, we want the world to be better and to be part of that. And in areas such as antimicrobial resistance, we can't solve this alone. So I understand wanting to be the best, but I also understand that this is about collaboration, and we need to change the language around patient safety. We also gave you the provocation. So I come from a background of improvement where an aim is how much by when. And I wanted a how much were we going to do. I didn't want to, we're just going to try and make things better. I wanted to know how much. And the art of the possible is said to be a reduction of about 50% across the system. But you didn't like that, so we've taken that out. But we still have great ambition. You challenged us on more about workforce. And we are working closely and have been challenged to work closely with the workforce plan, and we will do that. You challenged us around the behavior of regulators, and I've seen this for myself. So organizations step forward and say, we have an issue around never events, and we're going to try and help, but in the meantime, other parts of the system are trying to work out how they can punish or fine them. So I understand that. And the absence of accountability comes up. And this is a difficult challenge. How do you balance just culture with people's desire to see people held to account? It's tricky, but we've got to work on it. And the complexity of the system, particularly at the center, what do all these bodies involved in safety do? And we will align better to make that more straightforward. And you also challenged us on an idea we had that perhaps we should have patient safety support teams going around supporting organizations, and this wasn't the approach you wanted us to take. But you wanted more on measurement, more on safety too, primary care, staff safety, and understanding the practical difference that this strategy would make at the front line and the role of patients and public. And we have taken all that on board. On just culture, the comments you made, it's no great surprise to find that blame came up more often than any other word. And actually, some of the surprises were about the words that don't come up. So those with good eyesight will see litigation's a tiny little word down here, and I'd expected to see more of that, for example. So you were concerned about the risk of blame. So here it is. We launch it here and now. This is the first time any of you will be seeing it. And we really, really hope that this is going to make the next steps for patient safety and make a sea change in the world of patient safety, and that you will appreciate it as a document, because it's not our document as the patient safety team. We have curated the words of others, and what I hope you will see in it is the voice of other experts and other people coming across. This is a co-written, co-produced document. And in it, we talk about these 3 areas. So in Insight, we talk about measurement, using digital technologies, particularly around the new reporting and learning system, changing from serious incident framework to a patient safety incident response framework, changing the language, taking out the more threatening words like serious, moving away from this concept of root cause analysis and what I call the iceberg problem. So if the Titanic had happened in healthcare, we'd have done a root cause analysis, blamed the iceberg, put out an alert saying avoid icebergs, don't go near them. We might even have tried to warm up the ocean. Well, I guess we're doing that anyway. But that's not the right response, and it doesn't understand the other parts in the system. So we're changing that. We're embracing the medical examiner system and making the information and insights from that part of our system. And we're looking at how we put out alerts, and I'll talk about that in a minute, and the insights we can get from litigation. So this is the NRLS. She's an old bird now. She's 15. In IT terms, that's ancient. We have, as you see, dramatically increased the reporting. So we have over 2 million incident reports going into that database, and the database has 20 million plus incident reports in it. And the breakdown, which I don't suppose you can read, is the top bar is the no harm data, and it's 3/4 of it, which is quite surprising in a way. And when you get down to the bottom of the deaths and severes, that totals 0.5% of what we're seeing, and that's where we're focusing our attention, because handling 2 million incident reports is not easy. And we need different ways of doing that. We are not making the best of this system. Of course, you look at all these incidents locally, but we can make better use of them nationally. So we have a new system. This is our tube map of the new system. Lucy, who's in charge of this, is getting very excited in the front row for those of you who can see her. But really what this system does is make it easier to report incidents, easier to use those data. The taxonomy is simplified. You will no longer be able to describe C. diff in 370 different ways and then hope to actually do any reporting around that. And we will make it easier to analyze and share information from this. And also, it will be easier for patients to report. I know the news has been whistleblowing app for patients, but actually it's about make it easier for patients to report when harm occurs, but also when good things happen. It will be easier to report positive information and learn from what goes right. So we have a world that loves a bit of random news about health, doesn't it? So whatever condition it is, it's either good for you or bad for you, whatever's going on, and also likes to report this stuff. And this is a recent one, and we frequently see this. And our analysts spend a lot of time answering freedom of information requests for data that then gets misused to say that increased reporting means increased harm, and uses language that is really unhelpful for us as staff. And it really distresses me the number of times where staff are described as blundering or incompetent when all they've done is go to work to do a good job and have been let down by the pressures of a system. So wouldn't it be good to move from this sort of reporting? And I'm aware, yes, I know the host is a journalist, and I'm at risk of dissing journalists here, but this isn't you, Sean. This should make the panel interesting. Wouldn't it be so much better if we were starting to see this sort of story, how the NHS is getting safer because we're learning from an open culture in which we feel able to report honestly and we don't feel the need to cover up? So in the insights domain, I also talked about the patient safety alert system. So you will have seen the alerts that we put out, and they're not always perfect beasts. We genuinely believe they have the opportunity to save lives. We know they do that, but sometimes they're not clear, and we don't always go out and reassure ourselves that the actions have been undertaken. So we want to get better at that, because the message can sometimes get a little bit lost. So if you look at the bottom of this, it says, also the bridge is out ahead, which is the key message. So we get better at it, and I think sometimes we focus a little bit on niche issues, perhaps not quite this niche, particularly like this report, rather than what you see on the right, which is much bigger issues where we're still seeing falls, suicide, self-harm, pressure ulcers, etc., as our major incident reporting. So we need to focus also on those. So in the involvement section, we talk about working genuinely in a more systemic way with patients, families, carers, and other people, and looking at how we structure that. A patient safety syllabus across the system. Patient safety specialists. Now, I know that many of you have patient safety specialists. I think they're quite variable. They don't occur in all units, and there's a lot of debate about this, but you are generally supportive of the idea of this. It occurs in industry. It does not mean that safety isn't everyone's business, but what we want to provide is high-level training both in the generic things in patient safety, but also how our system works to support people to think about their systems and structures. And we want to learn more from what goes well as involve the whole health system in this. And here are some examples that our patient partners have been looking at of how they can become involved in the system. The syllabus isn't going to be something we start from scratch on. The WHO has a patient safety syllabus, other countries have them, and there's work here that the Academy of Medical Royal Colleges has already been doing with HE, and we want to build on that rather than start from fresh and have different levels of learning in the syllabus. And I understand, as well as anybody, that education and training and the people-focused areas sit low down in what's effective in preventing harm. But this is about training to help you actually understand the top half and do more of it. And in the improvement domain, we have a lot of programs that you'll already be aware of. We want to continue to support the National Patient Safety Improvement Program through the Patient Safety Collaboratives. We want to continue to work in the world of maternity and neonatal safety, as you would expect, introduce much more on medication safety. So we know that there are about 237 medication errors a year in England, a staggering amount. 66 million of those have some degree of impact, and we need to do more on that, as well as focusing on mental health and giving it parity of esteem, and continuing on those so-called giants of patient safety, falls, pressure ulcers, etc., and supporting people in priority areas such as thinking about safety of the elderly and those with learning difficulties, and playing our part in antimicrobial resistance. So you will know of these programs. Here they are described. We expect to see more of this. But back to this hierarchy of effectiveness, the other thing we need to do more of is design of our safer systems. How do we make it easier for people to do the right thing? And we're not very good at adopting these technologies and innovations. So there are some examples here. There are many more. So scanning, for example. The one in the middle at the top is an arterial cap to stop you injecting drugs down arterial lines. Not everyone likes it. So there's a tendency to go thumbs up or thumbs down, and it never sees the light of day again, rather than iterating and developing. On the right, RFID in swabs. We still leave a lot of swabs in people. Technology exists. It's not CE marked yet. Don't know why. It's used in the States in 850 different organizations. That could help us. Simple things like trying to stop us doing what we do frequently still, which is connecting people to air when we meant to connect them to oxygen. And other things that already exist that we might adopt. So this Edding pen is an X-ray opaque marker. Maybe that could help us stop taking out the wrong ureteric stent, which we sometimes do still. So plenty around design in the system that could help us. And we have patient safety translational research centers, 3 of them. We have innovation pipelines in AHSNs. So we know that there are some things we can do, interventions that will work in patient safety that we could roll out nationally. We know there are some ideas we can test, but we also know there are gaps. And we need to be more deliberate about how we fill those gaps. And I think there is a place for us now building a patient safety research strategy to think more carefully about how we engage with these organizations to fill those gaps. Scary one. This is really just a slide to say a couple of things. One, we are thinking about holding ourselves to account and timelines for delivery of this. And secondly, we will review this. We want this to be a fluid document. We don't want to be writing a patient safety strategy too often. There's a lot of effort goes into it. Matt, who's done more work than any on this, I guess, is sitting there thinking, thank goodness it's over. But it's not over. It'll never be over. We want to keep looking at this, and we'll look at it annually and update and revise as needed. And if we get this right, what could the impact be? Because it's really important we look at that impact. We want to be able to say in 5 years' time that we can measure that the system is safer. And of course, these are estimates, and it's difficult to estimate. So if you just look at training, there are other industries where by training staff, they believe they've reduced the level of harm by 50%. We're not trying to claim that. We don't believe we'll achieve that. We've moderately estimated that maybe it'll have a 2% impact. Of course, it's a little bit finger in the air, and we'll be challenged by the academics on it, but we're trying to get to the point where we can measure and look at impact and predict what we'll have. And if all of these are added together, that's what we believe we could achieve, and maybe more, once we've introduced this strategy. So that's what we're driving towards. And we're also driving towards this. So when I was working my previous job in Wales, we celebrated 70 years of the NHS. We want more of you to feel like this. This was somebody's label on a laptop, to feel, I love working here. Just my final comment, I think many of you will be aware that September the 17th is the first ever World Patient Safety Day in the hands of the World Health Organization. I'd love you all to start thinking about what are you going to do to celebrate this day and further the cause of patient safety. It's coming up soon. There'll be things happening centrally, but please think about how you can make a contribution. We've died. It was all going so well, Sean.
Well, thank you very much for that, Aidan. I think he deserves a round of applause for that. And before I invite the panel to respond, I do believe we have a small video from somebody else who wants to respond to your strategy, Aidan.
So all that was left was a slide saying thank you and a link to the strategy, which was very important for you. But maybe they can work it from the desk.
I think we're going to see a video response now.
It's a great privilege to be able to talk to you today. This year's theme of pushing boundaries, spreading knowledge, transforming practice lies at the heart of my ambitions for the future of the NHS and of all of our desires for an NHS that's the best it possibly can be. My only regret is I can't be with you to express this in person. Patient safety is such an important priority within the NHS. And I'm delighted that the NHS Patient Safety Strategy that we announced last year and that Aidan Fowler has done so much hard work in bringing to fruition, I'm delighted that it's being published today. It provides a coherent framework for safety improvement and a clear vision for NHS staff and patients. And of course it dovetails beautifully with the work already launched on health tech and on prevention and on the people plan, my 3 priorities that have patient safety as the golden thread running through them. We need to make sure we've got the right culture in the NHS, where nurses, doctors, allied health professionals and the wider team feel able to deliver the safest care and not be afraid to speak up when they feel that work falls short, and not be afraid to accept and to discuss themselves when things go right and when things go wrong. Keeping patients safe also means keeping NHS staff safe from bullying, violence and intimidation. Hence the interim people plan is not only about recruiting the right staff with the right skills and values and retaining staff, but also about creating a supportive, empathetic and open culture where excellence can thrive. That's how you build a safe culture. But even in the best healthcare systems, sometimes things go wrong. Of course they do. This is, after all, a risk-based business. And we know that the physical and the emotional and the economic costs can be huge. When things do go wrong, it's vital that we learn from mistakes, encouraging fairness and promoting a just culture. That is at the heart of reducing patient harm further. Now, there's 2 things I wanted to go into in detail. Clinical negligence is the first, because clinical negligence can have serious consequences for patients and their families, carers and for staff. And it's so important the NHS says sorry and can feel able to have that empathetic response when something goes wrong. So today I'm welcoming the launch of the NHS Resolution Guide on Being Fair, which supports a just learning culture for staff and patients and provides guidance following incidents in the NHS. Part of the problem is that compensation payouts and legal costs have increased so much, from 400 million just over a decade ago to 2 billion last year. This is despite evidence proving that there has been no decline in the safety of care that patients receive. These rising costs of compensation claims are increasing faster than funding, threatening to erode the record money, the 33.9 billion a year that we're putting into the NHS as part of the long-term plan. And of course, that puts risks to the plan to improve our health service set out in the long-term plan. It's absolutely critical that as much of the dedicated funding from the NHS as possible is spent on patient care and on the front line, and money spent on damages and legal costs reduces resources available for frontline services. We must tackle the costs of clinical negligence, and one of the ways to do this is by handling problems and errors and complaints in an empathetic way, and that often starts by clearly saying sorry. The second area I want to touch on is technology. Technology has a vital role to play in the patient safety strategy, and I want to highlight the current gains that we've had, and there's loads still to come to fully embrace technology within our NHS. Electronic prescribing is already having an impact on reducing medication errors, has a huge potential. The long-term plan clearly explains how digital technology is going to provide patients with more convenient access to services, to information, and to other resources. Meanwhile, the new patient safety incident management system will modernise the way the NHS reports and learns from errors. This is incredibly important. It'll ensure we capture more records of errors and unfamiliar risks, and be more accessible to staff for learning and improvement locally, and allow us to use the data better to understand where problems occur and therefore learn from it. The huge potential of technology is why I set up NHSX as part of the NHS to work with the department, with NHS Digital, with Public Health England, and with the social care sector, fusing digital expertise with clinical excellence and having it as a core part of the NHS. That's the only way we can get the best out of technology. And I'm convinced this will lead to major improvements. For instance, whether it's in screening services, in mental health, and in directly improving patient safety so that we can take a data-driven approach and we can learn from incidents right across the NHS and bring those learnings to improve the way that we deliver care. It's all about meaningful and lasting impacts on patients, on carers, and of course on our staff. I'm incredibly grateful for your hard work and your dedication to the cause. The cause of patient safety is a vital one. There's many more challenges that lie ahead, of course, but I'm confident that together we can make the NHS not only the best healthcare system in the world, but also the safest. So thank you very much. I hope you have a great conference, and I look forward to the work we can do together in the days, months, and years ahead.
Well, a word there from the future Chancellor. I was tempted to change his... tempted to change the captions. You know, they do the translation and say what I think he meant. But I don't think I was allowed, so I didn't do that. But there we go. We have an excellent panel here now to discuss and talk about Aidan's new strategy. Hopefully we're all going to tear a few strips out of his plan, and then you're going to do that as well. So do make sure you submit some questions via the app on your live Q&A. But first of all, let me introduce our panel, who are excellent in every way in this, and we're going to have a great discussion. And so right at the end there, we have Professor Lord Aradazi of Denham, who's the Director of the Institute of Global Health Innovation at Imperial College London. Next to him, we have Scott Morris, who's our patient speaker this morning on the panel, and father of Sam, and who is an excellent and very eloquent speaker on all things safety, and we're pleased to have him on the panel. Next to Scott, we have Alison Leary, who's the Professor of Healthcare and Workforce Modelling at the London South Bank University. And next to her, we have Professor Anne-Marie Rafferty, President of the Royal College of Nursing. Now, Aidan, chair's prerogative, and you did have a go at journalism while you were in your speech.
Yeah,
so, your slide mentioned the study around 11,000 potential avoidable deaths from issues and incidents. But I noted the other slide which said your strategy is going to save 1,000 lives. So there's a 10,000 gap there. Just talk me through that.
So the numbers are really difficult, and there's challenge in the press about these today. So they're based on the well-known Hogan study, and Arrow was part of that, and accepting that that study was of acute care. So we have estimated, based on the proportion of deaths outside acute care reported to the NRLS, what that means for the whole system. So it is an estimate. So it's in the strategy with caveats, but we felt it was important to try and start to measure the potential impact. As far as that very reasonable challenge about why don't we want to do more? Well, clearly we do. We would like to avoid as much, and the term avoidability is really difficult. So the study was based on people estimating that any errors in care might or might not, on the balance of probability greater than 50%, have led to death. And these are often elderly patients with great degrees of comorbidity, some of whom are at end of life anyway. So it's a very difficult field to measure in. What we have tried to do is design a strategy that we think will have the best impact we can achieve currently on the system and make estimates of that impact, and we have been conservative with it because we do not want to overpromise. So, of course, we would like it to do more, but hope is not a plan. And I think the key thing is that we are trying to measure the potential for impact of the things that we're doing. And along the way, over the next 10 years, we would expect with technology and innovation to get to the point where we can increase that figure.
I wanted to just tease out one specific from the strategy, which I've spotted this morning, was around the new patient safety incident framework that you're going to develop, and particularly that talks, I'm sure a lot of people in the room will be very familiar with the process they have to go through to investigate a serious incident. And there's a line in the strategy around maybe moving away from the traditional thresholds of an incident investigation, and maybe doing fewer investigations, but those that do more learning, and scrapping the 60-day deadline for serious incidents. Just talk me through that framework and how that might impact on the people in the room who are going to respond to these.
So there are, I think, a lot of changes in the framework, and what we'd initially planned was to publish the framework alongside this strategy, and the feedback was that actually people said, well, normally in improvement we test things, so why don't we test this before we publish it broadly and make sure that it makes the changes that we want it to make. And there are a number of areas around that. I think in terms of thresholds for investigation, we know that investigations aren't always done well, and we're looking at how we train people, and we're working with HSIB on how do we train people to do better investigations. How are they less threatening to people, because we know we'll get more information if people aren't feeling that they're being dragged into a room with 3 people on the opposite side of the desk asking questions. And I think the threshold thing is important because the risk is that where we are in patient safety is that sort of, if you look at patient safety culture, bureaucratic phase where we're gathering lots of insights, which are important, but the actions are critical, and we have limited resource. So if 2 people fall on a ward subsequently for the same reason in the same circumstances, the investigation of both may only reveal the facts that you would get from one. So the question is it appropriate to say we must investigate all these things, or is it better to investigate, find the cause, work on that, act, and then reinvestigate when you find that people are still falling afterwards? So it's about trying to be proportionate about that. And in terms of the timescales, by setting rigid timescales, that becomes the thing rather than getting the best investigation you can.
Well, let's open this up to our panel, and feel free to interrupt and jump in. I want a real discussion here. But Ara, if I could start with you. I mean, you've been in this field for years now. You're former minister of the Labour government, and you obviously lead the work with the Patient Safety Translational Research Centre at Imperial. I hope you've managed to have a brief look at the strategy. Give us your initial insight into what you think, and tell us where Aidan maybe has not quite got it right and where he needs to improve.
Thank you, Sean, and thank you for inviting me here today. I probably will talk as a clinician with a passion on safety. I don't think I've achieved much as a minister talking about safety. So, well, I'll start by congratulating Aidan. I think this is a fantastic piece of work. I think, and I strongly recommend reading it. It's much more exciting than Gordon Brown's biography. I think it's written in the right tone. It's not a list of things that you need to do. It provides you with the intellectual discourse of how could I translate some of this, depends across the room what your background is. I think it captures the continuity of what has been achieved in the past decade, actually taking us all even to the first report published by Liam Donaldson many, many years ago, and then continue to work under Mike, and now aid in joining, but also trying to predict and exploit the opportunities in the future on the back of innovation. So refining the past, and I suspect one of the best examples would be the patient safety incident management framework. I think that needed a change because we've had a 10-year, about 10 years using the NRLS. If I'm correct, Aidan, it has about 12 or 13 million incidents in it.
20 million.
20 million incidents. So on average, we're capturing about 1 million or 2 a year? Or
2 million per
2 million
plus per year, yeah.
So, which is very useful, but the NRLS had the R and the L. I don't think we've exploited the L in any way, the learning opportunities from this, and I think relaunching that is critical. I also believe, which I haven't seen here, and that's not a criticism, is from a staff perspective, the separation of what is a voluntary reporting, which I think we need to continually encourage, to what is an incident that has to be reported, like a never event, for example. And I think those two get muddled with each other, which actual fact may compromise voluntary reporting. And I believe we can learn a lot from voluntary reporting. If you could take the vincristine injections, intrathecal injections, I mean, that was something that was picked up through that route. So I think that's the second one is the patient and the public involvement. I really was captured by that. I think patients have so much to add in terms of scrutinizing, shifting the balance of power when it comes to what they may consider as a neglect, which could end up, and we've seen examples of that throughout that wonderful video about Nick. So I think there's a lot to be learned from that. So I think great document, and the other thing about it is is what Aidan showed us, huge amount of agreement of what is in the document. So certainly more agreement than Brexit.
Consensus is breaking out in patient safety. I'm down with that sort of thing, I say. But Scott, give us the patient voice. Disrupt the panel. Tell us your thoughts on this. Tell us what I know you had a chat. You and I had a chat this morning about this, and there was something specific that you wanted to raise.
Yeah, I mean, it's just my patient perspective, and there may well be a range of others, but I'm pleased to see a document starting with mention of just culture, starting with psychological safety, referencing much greater involvement, more formal involvement of patients in the development and understanding of things. But I guess the way I look at things is often to see what's not there as well. And what I didn't see was, although I saw reference to blame, I didn't really see an understanding about why that's part of the system. There's reference to fear, but not its root cause. And I was disappointed not to see much more about that, because I think you need to trace it back to its roots in order to have a hope of this strategy landing and achieving what you want it to. Within the document, it references the fact that culture change cannot be mandated by strategy, but strategy can be completely destroyed by culture. And for me, in addition to all the positives there, please let's add to it a proper shared understanding of what we mean when we talk about just culture. And let's also look really deeply and profoundly at where that fear comes from, because unless we do that, we have no hope of ironing out however many strategies get published. And it's not meant critically in a cynical way. It's very much meant in a constructive, critical tone. But that would be my takeaway after one very quick reading.
Well, it's fair to give you a quick chance to... Thank you, Scott. And it's worth saying for the audience who probably haven't had a chance to read this yet, there is, Scott mentioned the involvement of patients. There is a requirement that patients will be on all clinical risk committees, I think, governance committees by April 2020, I think it is, which is a formal requirement to involve patients. So that's, I think, what I was referring to. But fair challenge from Scott there around the definitions.
There's always a fair challenge from Scott, which is actually taken in good spirit. I think that's a very good point. I mean, the Secretary of State works very differently from the previous one. With the previous one, I'd have been in the room every week. I've been allowed to get on with this, but the one thing he has said is, I don't understand, you work in a business that is about risk, and why are you embarrassed to talk about it? We must get rid of all the factors that stop people speaking up. And the question, I guess, is do we really understand all those? So you saw the word blame in highlights there. And the thing that surprised me when I'm thinking about what I think makes people reluctant to speak up, not all of those came through strongly. So is it the coronial system? Is it litigation? Is it something about organizations? And I think there's lots more we need to learn about exactly what is inhibiting people speaking up and creating this culture of fear, and learning more about how we create the culture of psychological safety. And, you know, with credit to you, people like you help us work on that journey. There's more to be done.
I would just like to add to that. I was regularly showing documents like the Being Open framework and the Organisation with a Memory when I was struggling to get anybody listening at all after my son died. These documents can be used as cover for inaction too. And I'm really keen that that is not allowed to happen in this instance. And for that reason, understand it's not just regulation, it's bullying, it's scapegoating, it's cover-ups. And that's actually happening on the NHS's watch all the time. Let's try and understand it. And if it involves changing regulation, then get Matt Hancock to address that too. Because if he doesn't do it, who will?
Yeah.
So.
An application for a new job as Secretary of State for Health.
No thanks.
Alison and Anne-Marie, I wanted to bring you in here. So you are both experts in the workforce field, and I think, you know, my own personal view is this needs to link up with the workforce plan, doesn't it? I just wonder if I could get your responses and your wider thoughts on the strategy, maybe.
Well, okay, great. I mean, I think patient safety, and I do applaud the document. I think it's really turning the dial up, as Aaron and Scott have already indicated, on the learning, which is one of the most critical ingredients of the system, and how we do that, and setting the psychological conditions for safety across the piece. And patient safety isn't something that exists on its own. It is a product of people, staff, and systems, and the way in which they interact. And I think understanding what the preconditions are for people to be able to operate effectively in the system. I'm very heartened by seeing on the list, and I haven't had a chance to read the document, only listening to Aidan now, of having workforce and accountability there. And also in the consultation document, there was the outright recognition that there's poverty of understanding of what safety actually is. It's again relating to this education point, that how much are we going to really invest in this, Aidan? I mean, you've set yourself, if I may just challenge you slightly, some industries do it, and I know Alison's an expert in safety critical industries, you know, can get their metrics down by 50%, and you've set the bar lower than that. I mean, yeah, I know you're calibrating expectations in a judicious kind of way, but actually, this is going to need a lot of investment of effort and money in order to skill up the workforce. We also recognise that we don't have enough people, boots on the ground as it were, to actually turn the dial in the desired direction. So I think focusing this, articulating with the people plan, but we are going to need to have, as more than political will and resolve, we are going to need to understand, to really motivate the existing workforce, but we do need investment in the workforce and building that kind of capability, that skill level, and the mindset and the consciousness to do that. And I really applaud the fact that we're hearing a lot about, if you like, the emotional environment and culture in which care is being conducted as absolutely at the centre of this. I've got more to say on the education side, but I'll let Alison come in there.
Thanks, Anne-Marie. I'm really, really pleased to see safety too as a focus. Really pleased to see that, rather than just the constant measurement of harm, which we never really seem to learn from. I'm also very pleased to see the professionalisation of patient safety, or safety generally. We must be the only industry that doesn't do that, or the only safety critical activity that doesn't do that. And I actually, a little plug there, I'm a trustee of Patient Safety Learning, and they're working on that, so do come and see us in the exhibition stand. But for me, it is, as Anne-Marie said, the thing about resource. You cannot have a just culture when the workforce is under so much pressure. And so I still meet organisations and I still meet policymakers that do not see the relationship between workforce and safety. And this has to be an exceptional area in healthcare. Other industries grasped this a very long time ago. And I'm really looking forward to reading this fully and reading about the workforce parts.
Aaron?
Yeah, I'm going to just change the context here. I think patient safety too is very exciting. Everyone in this room goes to work in the morning with the aspiration of delivering the best care they can. They don't go to work in the morning thinking how many errors I should avoid. And I think that is the right narrative. Because if you can, and that's the culture of the organization, if the culture of organization is, our organization is here to serve and deliver the best quality care possible, which is what the patients are expecting, then I think a lot of the safety side will become a given. And I think that narrative is very important as part of this strategy, because if we start boxing safety as one thing, it may defeat that cultural transformation that you're trying to achieve. I think everyone also needs to recognize, by the way, this is not an NHS problem. This is a problem that affects every healthcare system in the world. In actual fact, we do reasonably better than many advanced healthcare systems. Just cross the pond to the US. You will see, because there's not a national system, we don't measure that, litigation is there, driven for all sorts of different reasons. So patient safety too is a very, I think it's the core here, and I think we should really drive that through. On the culture side, if we could just agree in what was said earlier, there was a publication recently, in actual fact, measuring the culture of the organization is the most powerful correlation with the safety in that organization. So you don't even have to measure the error rates. Just look at the culture. You could at least predict what the safety incidents are in that organization. So it's sort of two sides of the same coin. And I think the culture and then the narrative that we're setting is absolutely critical in staff engagement. Everyone in every system is under pressure too. If you go out to the United States, could I just use and this is something we're doing at the moment, part of the Patient Safety and Translation Research Center, which Aidan has very kindly mentioned, is the rate of burnout of staff. And the burnout isn't just the workload. All sorts of reasons why burnout. Junior doctors' burnout is one of the most challenging things facing the NHS at the moment. Junior nurses' burnout is another major challenge facing us. We started with Nick and the learning disability. I was on the quality subcommittee of NHS Improvement Board, and the big challenge there, we are not even recruiting into our training ladder of NHS staff into learning. So let's go back into thinking about the basic principles of what brings us to work every day.
Marie, you wanted to come in there, but I'm going to come out and ask the audience their questions in a little while, so if we can...
Maybe 2 quick points in response to Ara. I think if this document or this opportunity, an occasion to actually reframe perhaps some of the motivational, I don't know what one we'd even call it, kind of pathways that we have for engaging in care, thinking differently about why we do what we do essentially. And I mean, I'm also aware, and it picks up the point on kind of data, that actually, certainly from a nursing perspective, there may be a series of utopian assumptions that are implicit in documents such as this, that we can improve this if we have all these other assets and resources at our disposal. And I feel that from the nursing point of view, certainly, the nurses are to some degree flying blind and underexposed to training. The data poverty is more extensive than it might be in other areas. Absolutely. Therefore, perhaps we need to reframe the way we think about professional engagement with this across the piece, and it's obviously a team issue. But you know, rather than thinking about values-based care, that actually we have the sort of technical accomplishment, which is really dedicated around some of the key metrics that we want to target for patient safety, that would embed those values as part of that kind of process. So it's a reframing of how we actually approach and think about care as a socio-technical kind of enterprise.
Well, let me, I just want to mention a few of the people are submitting their questions, which I think is, I want to bring this in. They're a well-trained audience because the top-rated question says, the root cause of poor safety in direct care is the impossible low ratio of registered nurses to non-registered HCAs on wards. Will this be addressed within the patient safety strategy? I think the answer to that is no, isn't it, Aidan?
So, I mean, the whole workforce area is a wicked problem, and actually, I remember having a discussion. So I talked about not tweeting anymore and how I got challenged, and I noticed one of the people challenging me and my tendency towards reductionism and siloing stuff was Alison. So I went and saw Alison to have a discussion about this so that she could challenge me. And one of the things we talked about was this workforce issue. And I was tending to say, well, there is a workforce plan. So there's a workforce plan that deals with workforce. This is a patient safety plan. And she brought me around to the thinking of the connectivity, which is clearly there. So we do talk about workforce. And I hope, Alison, you'll see your influence on the strategy. One of the challenges from the NHSIE board last week was to work with them on the strategy. There's no easy answer. All I would say is that I have worked with people over the years on looking at ratios and staffing and understanding it better, and that's clearly really important to do that work. But at the moment, we have a series of vacancies in staffing. And sometimes what I've seen in organizations as I've worked in them is a tendency to worry about transfusion before you worry about bleeding. And we hemorrhage staff, and it's important that we stop that hemorrhage, and then we transfuse, and then we think about the right numbers. But creating a series of more vacancies is not going to solve the problem. So yes, those ratios are absolutely important. And I remember years back when we were doing the Kia reviews, my feeling from doing several of those and looking at them was that if there was a single element, and of course there wasn't, there were multiple factors, it was what had happened to the nursing workforce. And at a time in my own role where we were pushing for increasing nursing numbers and did so, some of these organizations had either been shrinking or freezing nursing. So it's clearly critically important. We know it's complex. We have our part to play, and we've been challenged to work with the workforce plan, and we absolutely should do that.
Again, another question that's roaring to the top of the list is a question from an anonymous person saying, practically speaking, how will the strategy help eliminate the toxic blame culture that currently exists in many of our healthcare provider organisations? Scott, was this your question, Scott?
Yeah, I just texted that without a phone.
But,
it's really cool.
but I'd be interested if we could to ask you, Aidan, practically speaking, how we'll do that. But also, I'd be interested in the panel's very quick suggestions of how we might do that.
Well, I'd encourage people to read it first and see what they see in there. The document isn't going to change things. It's the actions in the document that we believe will.
Okay.
I would like to see a practice of a handover when everyone starts their shifts, that they actually remind people of what you're trying to accomplish, codes of conduct and actually ground rules for operating that helps just to cue people in. And we rarely do that, and I think that might be something that helps just to kind of create the right headspace for some of these behaviours.
Alison, you delivered the James Reason lecture last year on safety critical industries and how they deal with some of these issues. Blame culture, how can we solve it practically?
I'm not sure you can solve blame culture, but explicitly valuing your workforce and explicitly valuing the people that you serve and listening to them gives a great deal of intelligence. Use it.
Scott, give us your perspective from a patient. How would you like to see this?
Well, as a patient, I thought healthcare was safe. So my big shock was that you had to have conferences for patient safety. And I think what I'm hoping for is that the focus shifts away from blaming people for things that go wrong to looking for leaders, that leadership, governance, and accountability comes back to regulation. That is actually trying to make sure that whether you're a member of staff or a patient, you go in, you get what's needed, and you come out in a better shape than you went in. And that has to be people working every day, and therefore it would be patients. But until you sort the regulation out, I don't think you're going to do it.
Ara, can I get your insight on this blame culture issue? And also I might ask you to address the next popular question, which is the role of the patient safety collaboratives and AHSNs, which I know in the PSTRCs you're all kind of working together in a similar field on that.
Yeah. I think the first question on the blame is an extremely good question, but addressing that is significantly more difficult. I am with you. I think we are over-regulated. I'm not a fan of regulation because that defeats what I said earlier. People come to work because they want to deliver the best care possible. So you need to get the balance right between encouraging staff that there are learning opportunities from this, encouraging a culture and organization of transparency, engaging the board of an organization, but at the same time, at a national level, we need to behave slightly differently too. Because if that leadership isn't across the whole system, from the smallest provider into the Secretary of State for health, we're never going to be addressing this problem. And this attitude of just a walk-in into a hospital as a CQC inspection, completely out of the blue, and start scoring on what happens on a static moment of the day is not going to pick up any of these incidents, or at least Nick earlier on, in terms of the experience that his family went through. So this is back to leadership and also the context, who is the messenger and what is the message.
Yeah.
In relation to the second question on the collaborative side, I think the collaboratives have played a very good role. I was delighted that with Aidan's arrival that he managed to renew the funding for the collaboratives through NHS Improvement. I think they need a more focus in areas to work on. I think we also need the diversity between the different collaboratives rather than all collaboratives doing the same thing, because it has to be a learning opportunity between the different collaboratives. If I'm wearing my academic hat as Patient Safety Translation Research Center, I see the collaboratives as the test bed of translating of that innovation into at least the evidence base that is needed for a more uptake in terms of adoption and diffusion.
Aidan, you've heard lots of comments, questions from the audience. Just give us your final reflections. This is the moment in the Congress where, again, you commit to something, which I'll have you back next year, you're having to deliver. But give us your final thoughts on what you've heard this morning.
I was just looking at some of those questions. So patient safety collaboratives, absolutely, we support them. I don't think we know exactly what the right scale for improvement is. Is that 2 million, 5 million? But it's not nationally, in my view. I think it's too big at 53 million. So we rely on having those organisations, and I can see opportunities to do more, and I completely take on board that at the moment the ask is quite directive, and we need that innovation pipeline, and we've got to balance that. As far as final thoughts are concerned, please read this strategy. If what it does is sit on a shelf, it's not going to work. Read it with an open mind, and I hope you will see difference. It starts talking about things we haven't talked about before, civility, for one, as being important. So I hope you will find it different. We have worked hard to try and engage with people and make this something that's different. So go out there, read it, and by all means feedback, because it will be a living document and we will learn over time.
Okay, well, I'm afraid we're out of time, everybody. I think our panellists and Aidan deserve a round of applause for talking us through the strategy this morning. Thank you, guys.